You're going to ablate the 8 diopters, or you leave 1 or 1.5 diopters for the future flattening that may happen with the cross-linking? Thank you.
If I understand well, that's the same question.
As we know, will induce flattening in the future, and that he improves myopia per se. Okay, so when we correct myopia 8 diopters in basic, shall we correct 8 diopters in total, or leave 1.5 diopters? That for the future flattening, that will be induced by the effect of cross-linking.
Okay, I don't let myopia. I correct all.
What is the lowest central corneal thickness that you work in this study? The second question is that you say that the key value has improved in general 3.5 diopters. I'd like to know the percent of PRK success in these diopters and the percent of the cross-linked success in these diopters. Thank you.
Regarding the first thing, we have to have 400.
Administrators wade through the increasing complexity of the business of medicine. Some of the big issues in ophthalmology are the same that we're kind of facing with all specialties right now. There's just a lot of uncertainty. And when it comes to uncertainty, there's a lot of just navigating new waters. So we're looking at EMR and meaningful use. We're looking at ERSing, and that's now going by the wayside. But now there's other things coming on the horizon as well. QRS is another thing. Once again, the SDR really want to come in and pay physician basics. That'd be really great not to have to worry on a yearly basis. We're going to have another 24% cuts. So those are the big issues right now in ophthalmology that we're kind of losing sleep over on a daily basis.
Today, the practice administration role is much different. Practice managers and administrators today have to understand lots of legal ramifications of what they're doing in their work, what they're practicing. They need to plan for the future, much more so than they used to. For example, coming up later this year, and something all practice administrators are now dealing with, is the change from ICD-9 diagnosis codes to ICD-10 diagnosis codes. That's going to take a huge effort on the part of every practice administrator. And because of that, administrators need to get educated, need to get knowledgeable about what it means to implement ICD-10. They have to work with their software vendors, they have to work with their staff, they have to work with their coders, potentially with outside consultants, in order to get ready to implement ICD-10. And that's just one of many things that practice administrators today's world have to deal with.
I think one of those concerns that we have right now is that ophthalmology is almost becoming a charity in some aspects because the cost of relationship goes up and up every single year. And that constantly that reimbursement going down and down every year. So there's that gap that we're constantly having to figure out the what if scenarios. What if it really happens? How are we going to fill that gap? So that SDR reform is critical for ophthalmology so that we can go ahead and become the best quality care possible. This is ASCRS ASLA Today.
Coast to coast, dust to dust.
SightPath is on the move.
Mile after mile, all year long, SightPath is on the move.
Our 200 employees travel 3 million miles a year.
To help our customers provide quality care close to home.
All we do is eye.
All day, every day.
Every day.
Join the movement.
two devices now for the first time promote your vision under conditions that mimic real-world activities. The Central Vision Analyzer and Omni Field. Visit booth 2121 for retest reliability like never before.
One of the most important benefits offered by ASRA is its unique accreditation program. The Certified Ophthalmic Executive Certification allows professionals to demonstrate a depth of knowledge in their field. Many on site underneath the state will be taking a CLE exam. The culmination of months of study and preparation will earn them a credential. Those who pass the exam not only earn the right to list the letters CLE after their name, but they also can proudly say they have achieved a level of professionalism and knowledge that will allow them to excel in the business of ophthalmology. This is ASCRS ASRA Today.
I want to make a difference. I want to be able to look my patients in the eye and say, we can do that. We can do that. Yeah, we can do that.
I can help you.
I know.
4 years of medical school.
9 years of church training. Rigorous residency training, fellowship.
I want freedom.
I want to innovate. I want to collaborate. I want to focus on patient wellness.
I don't want red tape.
I want to feel that passion again. I want to put health back in healthcare. Visit our booth to learn more about healthcare and discover the freedom to practice as you please. Give in to peer pressure. Learn why corneal biomechanics matters with Western Technologies. When it comes to laser vision surgery, is it better to have technology that does more or less?
Need to be different. Yes, as long as it has to be close, you get more options.
Like what?
Well, when I'm on my bike, I can fly up in the air when I go across. Like a boat. You rent a boat. You rent a boat.
Here's a boat. You didn't know. It's not counting. Only the wave lines can get by. The broadest rating and treatment options. You have like options, right? This is the outcome.
And treatment of corneal disease. In addition to the annual corneal day, ASCRS offers a wide range of sessions that will address hot topics that focus on the cornea.
Some of the hot topics should be system high entry and a number of U.S. trials studies how to use the practice. And if you're not involved in one of those, you'll have a site how to close the loop. We're really finding that both from the data here in the U.S. and data in other countries that that's really becoming a major procedure for hopefully halt so that's a big one to on this. I think otherwise there's some new diagnostic techniques for dry eye disease and there's some treatments that will be on the horizon. I think if you're looking at surgical options, certainly manipulated keratoplasty has been a very big topic in all that news the last few years. And then the new remote techniques that would be face surgeries, which are going to from diseases in the appear function. The way to really start is provide clinical
And really, 10, 15 years ago, the only people who cared about the ocular surface were cornea specialists like myself. But refractive surgeons, cataract surgeons, and this kind of emerging field of refractive cataract surgery really rely on a quality ocular surface to get the outcome that these patients demand. And the number one reason why patients have dissatisfaction with their surgery is the ocular surface. So we are seeing this interest outside the field of cornea, and we're helping our colleagues in cataract, refractive, and glaucoma, and even retina talk about the importance of diagnosing and understanding the ocular surface, and then treating this problem and getting better outcomes. So it's really the understanding of the medical aspect of cornea that has raised the interest level significantly. And then finally, as corneal surgeons, we have more to do than just the penetrative keratoplasty. And for decades, we did one operation for corneal disease, and really looking back, it's almost embarrassing to see that we didn't do kind of cutting-edge surgery as other fields were evolving. And now we realize that anatomically, part of the surgery, we can do better surgery, faster visual recovery, and kind of less morbidity to the eye if you will. So if you have a patient with endothelial disease, we're going to replace the endothelium. We're not going to replace the entire cornea. We're going to do DSEC or DMEC surgery. We're going to have good vision within a few weeks, not a year. If a patient has a corneal scar, we're going to do a deep anterolamellar keratoplasty. We're going to replace the scar, but retain that posterior layer of the endothelium, which the host needs to have long-term survival of that corneal transplant. It markedly reduces the risk of rejection. Again, anatomic targeted surgery. And finally, the growing field of ocular surface transplantation. Probably the biggest challenge we have in all of cornea, the patients with severe disease of the surface and the limbal stem cells. New techniques, new medical management, and new surgical procedures to restore these patients who no longer are blind and deferred to other treatment. There's a lot of interest in cross-linking, and of course, the West is lacking behind because we have the approval of this procedure. But we know from our colleagues all across the world that cross-linking can really help patients with corneal ectasia. A group of patients with keratoconus diagnosed at a young age, and we know are going to progress or may need a corneal transplant. If we can identify those individuals and cross-link that cornea, it will save that young patient from a subsequent keratoplasty in the future. And those are tremendous so, and then the complication of LASIK that everybody hears, the post-LASIK ectasia. Again, if the patient has developed this problem, really in the past have no treatment, we just watch that cornea become steeper with more astigmatism. Now, if we identify that patient with cross-link, we can prevent that disastrous severe ectasia problem. So what we're seeing in the U.S. is corneal surgeons are just saying we need to provide